I am delighted to be here and happy to know that everyone here is interested to learn more about sleep. Well, I am Dr. Truong. I am a sleep physician and also board certified in internal medicine. I did my training at Stanford and UC Irvine and also have a master's in public health from UC Irvine. One reason why I chose sleep medicine is because it's actually a rather new field. We are still learning a lot about why we sleep and the different pathologies of sleep disorders and how to treat sleep well. So I do have some publications in my sleep career. I'm also the medical advisor for Full Sleep, which is also represented by Katarina and Marcy here today. I have been very proud and impressed by the technology of Full Sleep and what they have to offer in terms of monitoring one's sleep and improving one's sleep quality. And Marcy and Katerina will talk a bit more about Full Sleep later. Today, I'd love to talk to you about sleep and menopause. Here is our discussion agenda for today. The first few slides, I'm going to focus on, what is sleep? What's a normal amount of sleep that we should be getting? How does sleep change with age? And then the latter half of this presentation will dive into menopause and how the different hormonal changes affects our sleep. Early on, there is a pen and paper activity. So just a heads up. If you have a second right now, you can grab a piece of paper, pen and pencil, or, this is Cyber Seniors. So if you want to pull up a digital notepad and type in that is perfect as well. But there will be a pen and paper activity to track your score in just a little bit. So before we move on to the next slide, I would like us to take a deep breath all together on the count of 3. Okay, 1, 2, 3. Thank you for doing that. So breathing, I think, is very similar to sleeping. We have been sleeping our whole lives and we have been breathing our whole lives. But it's not until we notice something different, something wrong with our breathing, then it becomes our whole world. Then it becomes very apparent. Breathing can change. It changes with hormones. For example, if there's an upshoot in adrenaline, we are breathing faster and we notice that we're inhaling deeper and faster. Breathing can change because of our habits, our very own habits, perhaps with eating or talking. It really changes how often we breathe and how deep of a breath we're breathing. And breathing can also change with how, what thoughts we have racing through our minds. And it's the same with sleep. Sleep can change with hormones, as we'll talk about later today. Sleep can change with our habits, whether it is, the timing of eating or alcohol use or other, things that we do in life unknowingly can affect our sleep, medications. And sleep can change with the thoughts that we have too throughout the day and at night. So just one thing to keep in mind about as we go through sleep. I'd like to briefly go through, what is sleep? A very simple question, but if someone were to tap on your shoulder at a bus stop or an elevator, how would you define sleep for them? In the medical textbooks, sleep has 4 criteria. So sleep is little movement. It's not no movement. We actually expect some movement in sleep when we're transitioning from wake to sleep stage, or during REM sleep, rapid eye movement sleep, there is some movement. There is reduced responsiveness. So if we are sleeping, at a new location and we hear a train whizzing by, we may wake up, but after several nights, our brain knows to take in that train sound and suppress it and allow you to sleep throughout the night. So there is this reduced responsiveness. But sleep is different than a coma. Sleep is different than death. I know that's kind of morbid. And it's different because it is easily reversible. Sleep also serves a function, number 4. It creates equilibrium. With sleep, we are re-energizing ourselves. With sleep, we are regulating our body temperature And with sleep, we're regulating our hormones too. So there is a bidirectional relationship with hormones and sleep. What is good sleep? Now, as a sleep doctor, when I talk to a patient, I want to know, at the minimum, 3 different things about their sleep to determine if this person is getting good sleep or not. One is timing. So we all have our own preferred biological wake time, biological sleep time, and that's considered our circadian clock. And everyone has a circadian clock. Our cells, our organs, our body operates on that natural clock. It may be different, and it differs in ages. Teenagers have a clock that's much later. We call that night owlism. Older adults have a circadian clock that's much earlier. So we call that early bird. And so between people of the same age too, your clock may not be the same as your partner or your friends. You may have a preferred bedtime that's very different and a preferred wake time that's different. My husband works at the fire department. And so knowing when a person sleeps, even though they get a full 8 hours of sleep, is so important, because if he's going to sleep after a 911 call at maybe 4 a.m., even if he gets 8 hours of sleep, he's not sleeping within his natural clock. And so that will affect his energy level the next day. So that's timing. Next is duration. There is a recommended duration for each age group. For adults in general, it's 7 to 8 hours. Professional athletes require a bit more, 9 to 11 hours of sleep. In the age group 65 and over, about 6 to 7 or 7 to 8 hours is recommended. It is a range with outliers, of course. So we do ask about duration at the sleep clinic if one were to come in to see us about poor sleep. And then lastly is quality. Quality means, when you are actually asleep throughout the night, what is your body doing? Is there something waking you up constantly? And quality of sleep is affected by your external factors, your room, the temperature, any lights, any sounds, maybe pets in the bed moving around. And then quality could also be affected by internal factors. For example, breathing, sleep apnea, or constant abnormal kicking, periodic limb movements, or restless leg syndrome. So quality is the next thing that we also ask about, and quality is something that we test too at the sleep lab. Okay, we have come to our activity. So if you have your pen and paper, please do take that out. This is called the Epworth Sleepiness Score. It is a subjective measurement of sleep that we perform on all of our patients who check in at the sleep clinic. And it's a standardized and approved and well-known way to measure one's perception of how sleepy they are. I would love for us to go through this. Once again, I am not offering, direct medical advice here, but I think this would be a fun activity for us to gauge how sleepy are we, today or this week. So there's 8 scenarios here for the Epworth Sleepiness Score. And for each scenario, please answer with a number. On the right, we have the numbers indicating that 0 means there's no chance that you're going to doze off in this scenario. 1 means there's a slight chance you may doze off. 2 means there's a moderate chance of dozing off in this scenario. And 3 means there's a high chance of you dozing off here. Okay, so let's go through these. Number 1 is sitting and reading. How likely will you doze off? Number 2 is watching TV. How likely will you doze off? Number 3 is sitting inactive in a public place. For example, you may be at a movie theater or a meeting. You're with others, you're not directly interacting with others, but you're sitting in a public place. How likely will you doze off? Number 4 is as a passenger in a car for an hour without a break. You are directly sitting next to your driver for an hour in a car. How likely will you doze off? Number 5 is lying down to rest in the afternoon when circumstances permit. Number 6 is sitting and talking to someone. You're actively talking to someone, sitting down. How likely will you doze off in this case? Number 7 is sitting quietly after a lunch without alcohol. And number 8, in a car while stopped for a few minutes in traffic. So here, number 8, you are the driver. You're in a car stopped for a few minutes in traffic. The next step is to total up your score and see how you did. So from 0 to 6, sometimes 7, that is considered not very sleepy from a sleep medicine doctor's eyes. 7 and higher is when we start to clinically diagnose sleepiness. You know, hey, this patient is quite sleepy. 12 is where the cutoff of where we are a bit more concerned. We would like to ask more questions. Scoring an Epworth sleepiness score of 12 or more is akin to driving under influence. So that's when it starts to get a bit more, serious. And this is also when we may want to perform a sleep test based on the history. Okay. All right, so that was subjective measurement of sleepiness. Subjective meaning, how does the patient perceive how sleepy they are? This slide focuses on the objective measurement of sleep. And I don't want to spend too much time with this, but on the left, we have a patient undergoing a traditional sleep test. And on the right is what a sleep doctor will see. It's just a small portion of the sleep test, but an important part based on the EEG brainwaves. So this is how we objectively measure sleep if you were to get a sleep test. There are other tests out there, such as a home sleep test. There's fewer wires. But one reason why I am just blown away by Full Sleep and very impressed by their technology is because Full Sleep is able to measure one's sleep duration and quality without these wires, without all of these, interference, things that may interfere one's ability to fall asleep and stay asleep. So much more comfortable. But in the sleep lab standard, this is the testing that we would do. Okay, so this slide really focuses on how sleep duration changes with age. So if you have noticed that you are sleeping less, yet not feeling quite so tired, that is completely normal. Sleep is a way for our brain to rejuvenate itself. Sleep is a way for our brain to form new memories. As we interact with the outside world, it takes a lot of energy, mental energy, but also thermal energy and metabolic energy too. So you can imagine that a baby who is interacting with the world for the first time is sleeping more than half of the day. A newborn needs about 14 to 17 hours of sleep per day. An adult needs about 7 to 9 hours per day, maybe less, or maybe more if they are much more active, like a professional athlete. And for older adults, 65 and up, 7 to 8 hours is recommended, but sometimes it could be 5 to 6, and sometimes it could be up to 9. All right, so what is menopause? Before I do jump into the definition of menopause, I'd love to talk about premenopause, which at this point, you can think of premenopause as no significant hormone changes. Estrogen and progesterone are, rising and falling in cyclical levels as expected. Perimenopause is when estrogen and progesterone starts to, go up and down. We start to see irregularities in the cycles. And this occurs 4 to 10 years before actual menopause occurs. Perimenopause is typically when women start to experience irregular periods, weight gain, mood swings, hot flashes, possibly hair thinning, possibly some memory changes. So perimenopause is when it occurs. Most of these symptoms, may resolve, but for some patients, these symptoms can persist for years into menopause. Unfortunately, for some, it may persist for the rest of their lives, hot flashes. But menopause, the definition of that is 12 consecutive months with no menstruation. And the average age that women reach menopause is age 51. Now, we tend to not have regular cycles of menstruation and then bam, 12 months of no menstruation. It tends to be more of an irregular cycle. For instance, during perimenopause, menstruation may skip, 1 month and then 2 months and then 6 months and then 12 months. And then that's when we can finally make the formal diagnosis of menopause. Now, there are two important hormones that decrease during menopause, and I mentioned those two already. So I'll share them right now. Estrogen and progesterone. Estrogen and progesterone is what really sets, our fertility cycle, the robustness of our fertility cycle. But not only that, it allows us to sleep well. Progesterone does have sedating effects. So having higher levels of estrogen and progesterone helps with sleep, protects sleep. Estrogen also helps with our body fat distribution, believe it or not. It tells when we gain weight, it tells our body to deposit fat in certain areas of our body, hips, breasts. And when we lose estrogen, then our fat distribution changes. So these two hormones are what decreases during menopause. Let's talk a bit more about the sleep changes with menopause. So first is timing, and this is correlated with what we define as good sleep: timing, duration, and quality. So let's talk about timing first. As mentioned before, everyone has a normal circadian rhythm. There's no right or wrong circadian rhythm, but everyone's is a little bit different. And when one reaches menopause, we tend to have an earlier shift of our circadian rhythm, and that's completely normal. That shift tends to be about 1 hour, or at least 1 hour. So if you have gone through menopause and notice that, postmenopausal, you are sleeping an hour or more earlier, that is actually really normal. What we also tend to really want to educate our patients is the waking up earlier. It turns out that a lot of our postmenopausal patients, when they come in, they're concerned that they're waking up at 4 a.m. And they're still getting a good 7 hours of sleep, perhaps, but they don't know why their body is waking up at 4 a.m. And that just seems very unusual and maybe pathological to them. But if they are still feeling good when they wake up, they're not falling asleep throughout the day, there's no new diagnosis of high blood pressure, and they're sleeping, relatively well throughout the night, then we reassure our patients, you're still getting a good duration of sleep. Your circadian rhythm has just advanced by, 1 or so hours, and now it's normal to wake up at 4 a.m. The second thing that is affected is duration. And this doesn't happen to every woman going through perimenopause or menopause, but it happens to a lot. Most perimenopausal women, about 90%, get perimenopausal symptoms: hot flashes, night sweats. These symptoms can be triggered by, anxiety, stress. And so about half of women experiencing these perimenopausal symptoms then develop insomnia because of these hot flashes and night sweats. So how that occurs is, sleep is understandably broken up, much poorer quality because of these symptoms. And in turn, certain individuals, perhaps genetically, they are predisposed to insomnia, or maybe there's an increased anxiety because of these unfortunate symptoms, or maybe they're staying in bed. Now they're watching TV in bed, or maybe on the phone in bed, and then that can lead to chronic insomnias. So a lot of different pathways, but insomnia can occur in half of the women experiencing perimenopausal symptoms. What we're seeing here is a sleep diary of a sample patient. And so this is when we ask patients to fill out, what time are you going to bed? That's the down arrow. When do you think you're actually asleep? Those are all the grayed out boxes. And then when do you wake up? And so here we see that, during the daytime on the left, this person takes 1.5 hour naps twice a week. They go to bed quite early, around 7 p.m., 8 p.m., but they're not falling asleep until 2 to 3 hours later. And so how to treat insomnia, this is a classic sleep diary for an insomniac patient. How to treat it is undergoing something called CBT insomnia, cognitive behavioral therapy for insomnia. You may have heard of CBT for depression, 12-week sessions with a psychotherapist, CBT for anxiety. CBT for insomnia is a little bit shorter. There's no discussion of, depression, mood, or whatnot. It's really focused on your sleep and your sleep schedule and how to retrain your brain on how to sleep. There's a lot of different tips and habit changes and sleep diary tracking. And so one pillar of CBT insomnia is teaching the patient, when to go to bed and when to get out. For this patient, one very common fix would be to asking them to sleep later. We want to save the bed for the 3 S's: sleep, sickness, and sex. And so if the patient is in the bed for about 2 hours, 3 hours at a time, and they're not asleep, we're going to ask them to actually get out of bed and don't go into bed until you're feeling sleepy later on in the night. It's important to do this with a trained CBT insomnia therapist. But this is insomnia and the treatment is CBT-I. Okay, so insomnia is, it could be quite counterintuitive for patients who are not aware of these CBT-I recommendations. What tends to happen for insomniacs is they get a poor night's sleep for a few nights. Let's look at the second to last night. That was a terrible night of sleep. Let's see here. They went to bed at 8 p.m. They stayed awake for 2.5 hours, then had very fragmented sleep throughout the night. And then they woke up at 8 a.m. They were in bed for 12 hours. Not good for training the brain that the bed should be safe for only sleep, sickness, or sex. But what goes through, this person's mind, we see very often in the sleep clinic, is that they are stressed out. They feel, bad that they didn't sleep so much that night. So they tell themselves, okay, the next night I'm going to go to bed even earlier to try to sleep earlier. We see this happen all the time. When they go to bed earlier, they think that they're helping their insomnia, but oftentimes they're doing the complete opposite. By going to bed earlier at 7 p.m. the next night, now they're in bed for much longer, wide awake, and then falling asleep later. So we tend to see a complete, about face of what actually happens to one's insomnia and what insomniacs actually think that they're doing. And so that's one, I guess, large pillar of CBT insomnia. We try to unravel that counterintuitive thinking. Okay, so the third effect of menopause on sleep is quality. Some may notice that there's increased snoring, perhaps new diagnosis of sleep apnea after menopause. And so first I'd like to dive a bit more into what is snoring. Snoring is the vibration of the pharyngeal tissues in the back of the throat. Now, our lower airway, if you can feel your throat right now, you probably feel your trachea. That's hard cartilage. That's your windpipe, wide open. But it's the area above your trachea, behind your tongue, that's actually soft and squishy tissue. That soft and squishy tissue back there also has the tongue in front that relaxes, gets larger, and falls backward at night. And this tends to happen in men because in men with low estrogen or no estrogen and progesterone, they tend to have fat increase on the tongue and around their neck as they gain weight. In women, not so much until estrogen and progesterone gets much lower. Now, when there's tissue that's vibrating, snoring occurs. When there's tissue in the back of the throat that is actually coming together, blocking your airway from actually suctioning air, then that is sleep apnea. That's actually occlusion of the airway. It's a piping issue. It's not so much something a medication could fix. It's really a mechanical issue. And so loss of estrogen redistributes the body fat, as mentioned, and leads to loss of muscle tone in the throat. What that means is our throat does get floppier, and our tongue size, our neck size do get larger after menopause, therefore increasing our risk of snoring and sleep apnea. Treatment for sleep apnea is abundant. Sleep apnea is so prevalent. And so treatment could be it looks like a mouth guard, mandibular advancement device. It pushes the lower jaw forward, therefore pushing the base of the tongue forward. It could be surgery. There are pacemakers for the tongue, or surgery to ablate the back of the tongue or cut out the soft palate. But my favorite and the gold standard, the most effective and least invasive treatment for sleep apnea is a CPAP machine. It is a continuous positive airway pump. Should be quiet, should be comfortable throughout the night. The main downfall of using CPAP is having a poor mask fit. When the mask is not fitting well, air is leaking out, and it whistles and it dries out the mouth and becomes very uncomfortable. Nowadays, there are masks that covers the nose or the nose and mouth. And I tell my sleep patients that, finding the right mask is like finding the right pair of heels to wear every day. You're going to have to try on a lot of different mask models and sizes. They come in small, medium, large. And when you find that right one, you will love it, and your sleep will be better. But it does take patience. So that is sleep apnea. Okay, so I'm going to end this talk with a getting better sleep slide. So one way to get better sleep is education. And being here today at the Cyber Seniors talk is such a great first step. Knowing what normal sleep looks like, knowing, things like what we just talked about, not going to bed if you're not feeling tired, education and knowing what normal sleep and amount of sleep should look like for your age group is so important, because there are a lot of myths and misconceptions about sleep. The second thing I wanted to share is the power of sunlight and exercise. These are free medications to get better sleep. And so studies have shown that 15 minutes of natural sunlight can do wonders in training your circadian clock and training your body to know this is wake time. I will be active. I'm going to wake up, and then training your body to later know that, it is nighttime and it's time to fall asleep. So 15 minutes of sunlight every day. Exercise is also a powerful sleep, trigger. A lot of patients who struggle with insomnia, when they start a gym membership, we recommend 15, 20 minutes a day. Could be walking or, light jogging or aquatics. That really helps with putting someone into deeper sleep that night and longer duration of sleep. Other good sleep habits, you may know this already. This is all over the internet. So avoiding alcohol before bedtime, avoiding caffeine at least 8 hours before bedtime, avoiding eating 2 to 3 hours before bedtime, saving the bed for the 3 S's, sleep, sickness, and sex, avoiding cell phone use, TV in bed, sticking to a consistent bedtime and wake time. And if, for some reason you are concerned of a sleep problem, detecting the sleep problem early on before reaching a pathological state would be best before, more serious consequences occur later on. So talking to your doctor about your sleep, if you notice increased sleepiness, new diagnosis of high blood pressure, new snoring, increased tiredness, new insomnia, that would be my recommendation.
Just wanted to give you a little bit of an idea of what full sleep is. Dr. Truong is our medical advisor, and we sponsored the webinar today. So what we've developed is essentially a program based on what Dr. Truong mentioned, CBTI, cognitive behavioral therapy for insomnia. It is the sort of proven best method to combat insomnia. It's an incredible sort of way to reset your subconscious relationship with your bed, try to limit any anxiety around sleep and, slowly but surely reverse your sleep troubles. It's typically done via a sleep clinic in person sometimes. So what we've been able to do is take the core principles of this and what works and actually put it into a way where you can do it at home. You can do it over 6 weeks. And if you're gone for a couple nights, that's no problem. What's unique about this is we have that little bedside device you see a picture of, and it's sort of there to help you. So you don't have to wear a watch or your Fitbit to bed. or any other sleep tracker, that bedside device will actually sense your sleep cycles, when you got into bed versus when you fell asleep, etc. And it gives you audio guidance in real time, to help you fall asleep and stay asleep. So for example, it knows when you've gotten into bed, and it will play a light sort of guided relaxation of your choice, followed by some nice sleep sounds. It will remind you when you're awake in the middle of the night that in order to, reset your relationship, you have to leave the bed. It's a great device. It's completely safe, and there's no cameras. So nobody is watching you. Nobody can hear you. It's completely private. You set it up next to your bed, and then you let it go. And we take you over a 6-week journey. The results so far have been really, really incredible. We've been able to prove that we're twice as effective as the closest competitor, because of the device also helping you to log your sleep and keep track of your sleep. Again, it's 6 weeks. You can do it at home. We have a promotion going on, a $240 discount. The program is $120 total. So we want to extend that to you all. It's limited to 100, the first 100. So if you're interested, I would say go for it. Just so you know, we have a 30-day money back guarantee. So if you do this for a week and you're like, you know what, this isn't for me, not a problem. You can send it back and we can refund you. It's only built for people with moderate to severe insomnia issues. So you will be asked to take a sort of qualification survey if you visit the website and apply. And again, it's just because we want to make sure you're safe. You don't have any health conditions that could actually be triggered by this, or be hurt by, resetting your sleep. It's an incredible program if you truly are, suffering with insomnia. And we hope to be able to, help as many people as possible.
That wraps up this talk. Thank you so much for your time and attention.